Okay, I think we will start now. Welcome. Thank you all for joining. My name is Alexandra Olsen. I'm a communications officer at the Alcohol, Illicit Drugs and Prisons program at the WHO Regional Office for Europe, and I will be moderating this session. This is the webinar series on alcohol and public health from WHO Europe, which started as part of a course for early career researchers, but we've been getting a lot of interest for the topics that are part of the series. So we've decided to make them public webinars. So this is one of the topics here today. And the webinar series is part of the WHO EU Evidence into Action Alcohol project, which is funded by the European Commission. So this is the whole webinar series, and you can see that we are about halfway through the whole series. Today is the 12th of July, and the webinar there are still two more until the end of the series. And the previous webinars are also, all the webinars are recorded. So the previous ones you can catch on our website, see them recorded. I will share it in the chat once we get into the session. Our topic today is alcohol and cancer, an overlooked link and decades of evidence and implications for policies. And it's a topic of heated debate, a topic where public awareness is particularly low. So we are very excited to have it as one of our topics in the series, and also very excited to have such great experts joining us today. And who are these experts? So our speakers today are Harriet Rumgay, postdoc at the International Agency for Research on Cancer, IARC, based in Lyon, France, and Kevin Shield, independent scientist at the Center for Addiction and Mental Health, and the head of the WHO and PAHO Collaborating Center for Addiction and Mental Health at the same center in Toronto, Canada. And I will stop sharing for a minute so that you can possibly see all of us. Yes, hi everyone. I also have online with me my two colleagues from the program on alcohol, illicit drugs and prisons, Maria Neufeld, technical officer, and Eric Harlan, technical consultant as well. We also have Dr. Jürgen Rem joining us, a fantastic scientist and expert on everything alcohol. So a very exciting crowd to have with us today. And the webinar will be structured as follows. There will be two presentations, first from Harriet, followed by a presentation for Kevin, and we will have sufficient time for Q&A. We will invite you, or we invite you already, to ask questions in the chat or the Q&A function. Both are working. My colleagues and the speakers will be replying to some of your questions in written form, but we will also have time to answer your questions live after the presentation. So I think that's it with the technical things. So without further ado, then I hand over to Harriet for your presentation.
Thank you so much, Alexandra. Yep, I'm just going to share my slides and hopefully you can see them okay.
Yes.
So as Alexandra mentioned, I'm Harriet Rumgay. I'm a postdoctoral scientist at IARC, which is the specialized cancer agency of the World Health Organization. So yeah, thank you so much for inviting me to speak today on this very important topic. And yeah, alcohol and cancer, it has been overlooked, but indeed there's decades of evidence to back up this work. So the evidence for the link between alcohol and cancer is not new. Drinking alcohol was first classified as a group 1 carcinogen, which is the most severe category of carcinogens categorized by the monographs program here at IARC. And they grouped that first more than 30 years ago. And the IARC monographs work looking at the epidemiological and mechanistic evidence. So this was first categorized as a group 1 carcinogen in 1988. But then it has been updated since then with further evidence and expanding the list of cancer types linked to alcohol in further editions in 2010 and 2012. So the cancer types that are linked with drinking alcohol, there are 7 different cancer types, and this includes cancers of the mouth and throat, also the larynx, esophagus, breast, liver, and bowel. And even low levels of drinking, so for example, 1 drink per day, can increase the risk of cancer. This plot you can see on the right-hand side of the slide shows the risk relationship between every 10-gram increase in pure alcohol that we drink per day. So that might be the equivalent of kind of 1 drink per day. And so this is the relationship between increase in drink per day and the risk of those different cancer types. And these risk relationships are taken from the meta-analyses, which are conducted by the World Cancer Research Fund as part of their continuous update project. So we can see that the risk does vary with some cancer sites. For example, esophageal cancer and oral cancer do have a higher increased risk per drink per day. But if we also look at, for example, breast cancer and colorectal cancer, where the increased risk is maybe smaller per drink per day, these cancers are some of the most common cancers in Europe and globally. And so this maybe small increased risk does have a big impact at the population level, which we'll see a bit later on. You'll also see that stomach and pancreatic cancer are included here because there's more recent evidence which suggests that they also have an increased risk with heavier drinking patterns, but this hasn't been reviewed or confirmed by the IARC monographs program yet. So just thinking about the different ways that alcohol can cause cancer, these are 4 of the major pathways through which alcohol can lead to carcinogenesis. So one of the major pathways is through the metabolism of alcohol to acetaldehyde, which can cause DNA damage and stop DNA repair, leading to cancer development. Drinking alcohol can also lead to changes in the regulation of hormones such as estrogen, which can increase cell growth and division. And this specific pathway is a major kind of suggested pathway for breast cancer. Alcohol can also induce inflammation and oxidative stress, leading to further DNA damage and cell cycle changes. And also people who drink alcohol might be deficient in folate and other nutrients, which are important for normal DNA methylation and gene expression. So these are just some of the pathways that have been proposed for alcohol-mediated carcinogenesis. There are other very important pathways as well, including liver damage leading to cirrhosis, and further to liver cancer. But many of these pathways are interlinked, which also shows that there's many options or many drivers that alcohol can go down to lead to cancer development. So with this knowledge of how many cancers are caused by alcohol, or how many different cancer types are linked to alcohol and their relative increase due to drinking alcohol, We also want to know what proportion of cancers globally or in different regions or countries are caused by that drinking. And we can estimate this by using a method called population attributable fractions to calculate how many cases of cancer could have been avoided if no one in the population drank alcohol. And we can do this using 3 types of information. So firstly, the amount of alcohol that people drink in countries across the world. So Kevin and Jürgen and their team do a lot of work compiling these estimates, which we can use in these calculations. We also want to use the amount that drinking increases the risk of those different cancer types, which are linked to alcohol. And then thirdly, the number of people diagnosed with cancer in each country across the world. And we compile statistics on that here at IARC. And so after combining this information, just looking at the global data here, or our global results, we found that around 4% of all cases of cancer globally were caused by drinking alcohol, which was more than 740,000 cases in 2020. This varied between countries and between regions of the world, which is largely linked to the different levels of drinking in countries or regions across the world, which I think Kevin will touch on later. But in this study, we found that the lowest percentages of cancer caused by alcohol were in countries in Northern Africa and Western Asia. And then many of the countries you'll see that have the highest proportions of cancer caused by alcohol, countries in the WHO European region, which I'll focus on now. So we found that around 190,000 cases of cancer in 2020 in the world, in the WHO European region, were caused by drinking alcohol. And that equates to around 4% of all cancers also in the region. And if we looked at the breakdown by different cancer type, we can see that around 1/5 of the cases of cancer in the region which were caused by drinking alcohol were actually from breast cancer. And this was followed by colon and rectal cancers. So as I mentioned earlier, even though these cancer types have a relatively low increase in risk per drink, when we look at the population level, they have a lot more cases attributable to alcohol due to being common cancers in the population as well. And when we separated the cancers due to drinking alcohol by men and women, we found that men represented around 2/3 of the total burden of cancer cases due to alcohol, with around 130,000 cases in the region, and colon and rectal cancers were the most common cancers among men. And then for women, around 2/3 of cases of cancer due to alcohol were from breast cancer. And so we think that this link between breast cancer and alcohol is something really important to communicate. And this is one of the infographics that was released along with, I think it was for Breast Cancer Awareness Month. So WHO Europe and IARC worked together to produce an infographic and communicate this link. And so also highlighting the increased risk, just from one drink per day as well. And we also highlighted this link in a couple more infographics when we released the results from our global study. So this is an infographic for France. Also, mentioning how many cases of cancer were caused by alcohol in the country, and then highlighting the contribution of breast cancer to that total burden. And similarly, we also produced an infographic for the UK with presenting the number of cases due to alcohol and an even higher contribution of breast cancer to the total burden, where nearly 1 in 4 cases of the cancers due to alcohol were from breast cancer. So in our global study, we also looked at the burden of cancer caused by different levels of drinking. And we found that more than half of alcohol attributable cases in the WHO European region were caused by heavy drinking. And then risky drinking also caused nearly 40% of those cases of cancer due to alcohol. But then with this study, we also provided evidence of the harmful effects of drinking at lower levels of consumption as well. So this moderate drinking category of less than 20 grams of alcohol per day, so that might be up to 2 drinks of alcohol, caused around 1 in 10 of the cancer cases due to alcohol in the WHO European region. So as I said, highlighting this burden of cancer even due to lower levels of drinking. Following this work, we've recently published a study looking at the wider economic impact of alcohol-related cancers in Europe. And we've estimated this using similar data on the number of cancer deaths due to drinking alcohol. This was for the European Union plus Iceland, Norway, Switzerland and the UK. And we gave each of those cancer deaths a monetary value depending on the age at death and the average amount of income that the person would have earned had they lived up to retirement age. So we calculated here the loss in productivity. We estimated that almost 5 billion euros in Europe in 2018 were lost due to deaths from cancer caused by alcohol, which was nearly 0.03% of the combined GDP of the 31 European countries. So we believe that this represents a huge loss to society, which would be at least double if we were to incorporate losses of unpaid employment, such as informal care, and also income lost through potential time off work or reduced working hours, as well as the actual or direct cost of diagnosing and treating the cancer before the person died. So to summarize what I've just gone through, drinking alcohol increases the risk of 7 different cancer types and causes around 4% of cancers in the WHO European region and globally. And this equated to more than 190,000 cases of cancer in the region in 2020. Breast cancer is a major contributor to cancers caused by alcohol, as it was coming up as the top cancer type due to alcohol in countries in the WHO European region. And from our latest study, cancer deaths due to alcohol cost nearly 5 billion euros in lost productivity in Europe in 2018. And this would be at least double if we included losses of unpaid employment, as well as the additional costs of reduced productivity and diagnosis and treatment. And to reduce this burden, we really need implementation of effective policy interventions to decrease alcohol consumption in the population. So before I hand over to Kevin for the policy discussion, I also wanted to show how these types of findings can be used. Here are some screenshots from a fact sheet that we worked on with colleagues at WHO Europe. And this was aimed at policymakers, and it was produced in Russian, French and English. And this is to really highlight the size of the problem of alcohol-related cancers in the region and to make policymakers aware of the policies that are available to reduce alcohol consumption. This work was also used to create a fact sheet aimed at the public to raise awareness of the link between alcohol and cancer and the policies that the public could also give support to. And we also worked on Another infographic with colleagues at WHO Europe, which clearly states that there's no safe level of alcohol drinking, and that the increase in cancer risk starts with just 1 drink a day. And another short infographic just simply describing the mechanism and how many deaths due to cancer caused by alcohol occur in the region. So this is one of my final slides. Thank you for listening, and thanks again for inviting me to speak today. I'd like to thank my co-authors on the various studies that I presented, as well as colleagues at IARC and the WHO Europe NCD office. I've put here my email address and Twitter handles if you'd like to contact me. And if you'd like to explore the estimates of the national, regional, or global burden of cancer due to alcohol, you can take a look at our web tool on the Global Cancer Observatory, the Cancers Attributable to Alcohol website, which is a really great resource to explore those data. And a few references, which I think will be in the slides, which we can share later. So thank you so much for listening, and I'll now hand over to Kevin.
Harriet, thanks a lot. Super interesting. And go ahead, Kevin. Thank you.
Great, thanks, Harriet. So Harriet just presented the burden of disease attributable to alcohol and cancer. So how do we prevent this burden? And what policies can be used and how effective are they is a really good question to answer. So to answer that question, we first need to look at the way alcohol consumption causes harms. Although alcohol consumption causes harms, it interacts with social and political factors. This would include policies, but also the local context of how alcohol is consumed, what are the public health policies, what's alcohol availability and marketing, but also individual vulnerability factors. So age and gender, genetics and familial factors, socioeconomic status. Those are really important factors that determine how much harm alcohol will cause per drink consumed. Another thing to take into consideration is how alcohol causes harm with cancer. A lot of that relationship is mediated through the volume of alcohol consumed. So unlike with injuries and with other diseases like ischemic heart disease, where binge drinking or heavy episodic drinking have a huge influence on the burden of those diseases and injuries, with cancer, it's a bit more straightforward in that the biologically relevant exposure here is volume. So what's your current alcohol consumption and what's your lifetime alcohol consumption? With that said, I'm going to bring up 2 caveats. With breast cancer, there's preliminary evidence that patterns of alcohol consumption, so heavy episodic drinking, may exponentiate that risk. So if you drink in a harmful way, that alcohol may cause more harm for breast cancer. Then we have historical periods of alcohol consumption. Again, this is actually with breast cancer, where if you drink alcohol between puberty and age at first birth, that alcohol may lead to a little bit more harm with cancers. And that's because those breast cells are undifferentiated and more susceptible to carcinogenesis. But with that said, the main mechanism by how alcohol causes harm with cancer is through volume. So the main policy mechanisms here would be affecting volume. So we just heard about the burden of disease data, especially for cancer. So what does this tell us and what does that not tell us? Well, it's great estimates to scope the problem. It tells us how many cancer cases and cancer deaths would be prevented if every member in a population had never consumed alcohol through their lifetime. We know that's impossible to achieve through current policies. Even policies like prohibition, you're going to get some alcohol use. And then prohibition is also going to come with other unintended consequences related to the criminality of alcohol use. So prohibition is off the table. It doesn't really work too well. And so we're never going to be able to get alcohol consumption down to 0. Then the next question arises is, well, how much can we reduce alcohol use while not causing unintended consequences? Well, for that, we can use a policy analysis. So for the burden of disease, the counterfactual we're looking at is people having never consumed alcohol throughout their lifetime. But we can modify that formula by changing the counterfactual to alcohol use under different policies. So if we increase taxation, that's going to decrease alcohol use. And so that's how we get at it. We use a burden of disease analysis, but instead of the counterfactual being lifetime abstention, it's reduced alcohol consumption. So in terms of the Europe's Beating Cancer plan, we have a couple different areas of action. And I want to talk about this in relation to alcohol. So we have prevention, early detection, diagnosis and treatment, and quality of life of cancer patients and survivors. For policy, I'm going to talk mainly about prevention, but I will note that early detection is an area of research with alcohol use that is emerging. So is it cost effective to screen for cancer among heavy alcohol users? And that's a question that hasn't been answered yet. Then you have quality of life of cancer patients and survivors, especially for secondary cancer. So cancers arising among cancer survivors. Reductions in alcohol can help prevent that as well. However, that's not the main focus of the presentation and not the main focus of alcohol's role in Europe's Beating Cancer plan. So before I begin the presentation in terms of the policies, I just want to give a brief overview of adult per capita consumption. So as I said previously, the main mechanism is how much alcohol is consumed, not necessarily the patterns. So adult per capita consumption gives us a pretty good measure of how much harm alcohol is causing in that population through cancer. So if we look at APC around the world, we can see that it's about 5.5 liters per adult. And here's an interesting dichotomy. You have males at 8.7 liters per adult and females at 2.2 liters per adult. If you think back to Harriet's slide, you can see that women experience a large portion of breast cancer. That puts them at higher risk per drink of alcohol consumed. So what do I mean by this? I mean, even though women are consuming less alcohol per drink they're consuming, they're actually experiencing more cancer harm because males aren't at risk for breast cancer. So the harm caused per liter of alcohol consumed or per drink is actually higher among women than males. So it causes a health disparity there. So next, I just want to briefly mention the impacts of COVID. COVID did decrease alcohol consumption. It's the only effective policy that has decreased alcohol consumption globally in recent years by 10.3% globally. You can see that it's a little bit mixed in Europe. Some countries increased their alcohol consumption, whereas Western Europe actually decreased their alcohol consumption. With that noted, we expect that through trend analyses and industry analyses as well, that alcohol consumption will recover by 2025. So any decreases in alcohol consumption in the European Union will sustain themselves by 2025. Now, with that said, we can look at the previous trends in alcohol consumption in the European region, and you can see a sharp decrease. Now, what would this be due to? This is actually due to policies implemented in Eastern Europe, specifically Russia, Lithuania, and other countries like Estonia, where this has led to large decreases in alcohol consumption, but also improvements in health. So will these trends continue? No, they won't, not with additional alcohol policies. These decreases are solely due to improvements in alcohol policy, which lead to improvements in health. But if you don't further change alcohol policy, it'll stabilize. So we don't expect any further reductions in the cancer burden in Europe or alcohol consumption without further policy action. So in terms of reducing the harmful use of alcohol in the EU Beating Cancer plan, you have various different roadmap strategies. You have the taxation of alcohol, the cross-border purchases of alcohol. This is really important for the Eastern European countries as well as Finland. You have the proposed mandatory labeling of alcohol, and I'm going to get into them in a little bit with an example from Canada. Proposed health warnings. This would be very similar to the mandatory labeling. implementation of brief interventions, and then young people's exposure to online marketing, which it's very similar to the best buys or SAFER. So if we look at the strategies and we map them onto SAFER, which is the WHO strategy to reduce alcohol consumption, we can see that they're very similar. The only difference here is that we're not using that A, which is advancing and enforcing drink driving countermeasures. Although this is an effective policy to reduce alcohol attributable harms, it likely isn't an effective policy to reduce cancers attributable to alcohol consumption. But we do have the others, so S, strengthening restrictions on availability, brief interventions, bans on advertising, and then raising prices. So with that said, how do these policies actually affect alcohol use and the burden? Well, if we look back to Harriet's data, we can look at how many of those cancer cases are attributable to risky alcohol use or moderate alcohol use. And so among people who aren't heavy drinkers, so less than 5 drinks a day, about 50% of cancers are alcohol attributable in those groups. By that, I mean that of all the alcohol attributable cancers, 50% are occurring in non-heavy drinkers. That means that we can't take a targeted approach if we want to prevent cancers. A targeted approach may be appropriate in certain situations, but from a public health perspective, we may not be able to treat our way out of this problem. And so complementary strategies are needed where we shift alcohol consumption down instead of just targeting the very heavy drinkers. So getting back to what I was saying previously, we can see that when we look at all cancer sites, and especially breast cancer, a lot of these cancers are occurring among moderate and risky drinking women and men, which means that if we implement brief interventions, these cancers won't disappear. So what can we do about that? Well, firstly, the most cost-effective way to do that is taxation on alcohol. Now, there are 2 different types of taxation on alcohol. There's specific taxation, which is based on ethanol content, and ad valorem taxation, which is based on the value of the alcoholic beverage. So how much you're paying. So typically in economics, what we use is ad valorem taxation because it's a progressive tax in that the rich pay more of the tax burden, where the poor pay less. But this actually presents a perverse incentive with alcohol. And by that, what I mean is it promotes the consumption of low value alcohol like beverages, but doesn't necessarily prevent the alcohol use. So what this means is that it just drives people towards lower priced alcoholic beverages. They don't necessarily consume less. However, if we use specific taxation, which is tax applied based on the ethanol content of the beverage, so €1 paid per gram of alcohol in the alcoholic beverage, you can actually lower alcohol use. So ad valorem taxation doesn't necessarily lower alcohol use, it just drives consumers towards lower value products, not necessarily lower alcohol content products, but specific taxation, which taxes ethanol content, does reduce alcohol use. So with that said, when you use specific taxation, you raise the price of alcohol, which is the most cost-effective way of reducing alcohol consumption and harms. However, specific taxation needs to be indexed to something to be effective. It needs to be indexed to either inflation or, better yet, affordability. If alcohol becomes more affordable over time, people will consume more of it. The point of putting specific taxation on a product is to reduce harms through making alcohol less affordable. If it is not indexed to anything, alcohol becomes more affordable over time. This encourages higher consumption. Then the next thing I'll note is that of all those alcohol policies that I mentioned, taxation is the most cost-effective. It is a net revenue generating policy as well. And this is because alcohol is a tax inelastic good. So that means if I raise taxes by 10%, I do not lower sales by 10%. I lower sales by below 10%. So any increase in taxation will actually increase tax revenue because it is a tax inelastic good. So what are the effects of taxation on cancer? Well, if you look at the whole WHO region, you can see that under various scenarios of increasing tax, you can prevent a large number of cancers. So if you increase tax by 100%, you prevent about 6% of alcohol attributable cancers. And that means the more you increase tax, the more cancers you prevent. So tax is a very cost-effective, easy to implement policy to prevent cancers. However, I will say that getting politicians to increase tax is fairly difficult. So although it's a very cost-effective measure, it's a fairly difficult measure to implement because it typically is viewed as politically unfavorable. So the next thing I want to note is the effects of increasing tax by cancer site. So as you have previously heard in my presentation, we're shifting that curve down. So that means that the more cancer cases that are occurring among non-heavy drinkers, the more tax will affect that cancer site. So for breast cancer, where a lot of the cancers are occurring among low to moderate drinkers, you're going to see a large effect of taxation. For pharyngeal cancers, it's still a large effect, but it is fairly relatively less than breast cancer. And this is because pharynx cancer is predominantly within those heavy drinkers. So to prevent pharyngeal cancer, taxation alone may not be a good strategy. You would need a complementary strategy of something like brief interventions. Next, I just want to briefly mention the effects of socioeconomic status on taxation. Now, this is from a modeling study on Holmes et al. 2014. There are still studies going on trying to show this not through modeling studies. So this is a thought experiment based on surveys and intentions, but not actual analyses. So that would be the caveat here. And what they showed in their analyses was that theoretically, tax should be fairly progressive in terms of its effects. So if you implement tax, the most sensitive to those taxation changes should be people lower in socioeconomic status. And why this is because people who are lower in socioeconomic status, when you increase tax, it makes the alcoholic beverage even more unaffordable for them. So the less money you have, the more unaffordable alcohol will become if you increase prices. So the next thing I'll note is low-hanging fruit with taxation policies. And this is an example from Ontario, Canada, where I am. But often what will happen, and this is minimum pricing, but it also applies to taxation, what happens is that when you look at the price, and this is per standard drink, but this would have also applied for taxation, you notice actually a heterogeneity across products. And in some European countries, some beverages aren't taxed at all. So a low-hanging fruit to prevent alcohol attributable cancers in terms of taxation would just be to level the playing field. Have a uniform tax across beer, wine, and spirits and coolers. Coolers are alcohol pops. To make sure that you're taxing the ethanol in the beverage. In a lot of countries, including Canada, we have differential tax rates for different alcoholic beverages, which may promote the consumption of one beverage over another. Typically, politicians are fairly receptive to when we bring this up to them to change policy to make sure that the tax is equal across alcoholic beverages towards the alcohol content. So making sure that there isn't anything in the tax code favoring one beverage or another, that you're actually taxing the ethanol within these beverages. Next, I want to note the effect of alcohol attributable cancers on public health communities and different policies there. Overall, the public is largely aware of the impacts of alcohol on health use. It's disproportionate. Lower socioeconomic status individuals and heavy episodic drinkers and heavy alcohol consumers in general are the most unaware of this. And therefore, there's a need for public health interventions, not just at that screening and brief intervention level, but other levels like public health information campaigns, which promote the increase of the awareness of alcohol attributable harms and the impact of alcohol on the cancer and health in general. So how can we do this? How can we improve the knowledge of alcohol's impact on health? Well, we could do many things, but before I talk about that, I'm going to just talk about brief interventions because that's the top of the pyramid. Well, brief interventions can reduce alcohol consumption and hazardous alcohol use, but you have to target hazardous drinkers. One thing to note here, and this is a meta-analysis by Kainer et al., is that the effectiveness of brief interventions aren't what we once thought they were. As time goes on, we're learning that the effectiveness of brief interventions are less and less. What that means is that brief interventions, although effective, may not be as effective as once thought. So getting on to alcohol policies and what we can do there. So we have alcohol warning labels. This is a study from the Yukon by Stockwell et al. We can see that the results of this study showed that if you implement alcohol warning labels, then that includes things like the guidelines, standard drinks, and alcohol can cause cancer, this lowers alcohol use. So just by simply putting a label on a beverage, you can actually increase awareness of alcohol attributable harms and potentially decrease those harms by decreasing use. And this was a randomized control trial where they randomized different districts and had control districts, and they saw that the districts with warning labels actually resulted in lower alcohol use. Another thing that we can do that has been fairly successful, at least in Canada, is communicate the risks through guidelines. So previous guidelines have set a threshold, and that's typically at 1 in 100 lifetime deaths. But the new method that may work better is communicating risk zones. So at what risk are you if you drink 1 to 2 standard drinks a week? What if you drink 3 to 6 drinks per week? What if you drink 7 or more? So putting a person's risk on a continuum allows us to meet people where they're at. So instead of being heavy-handed and saying you have to meet a certain risk threshold, the message here is fairly clear: less is best. So this may be an effective method for reducing alcohol use as well. However, we haven't evaluated how effective that is. And then with the guidelines, we give various different recommendations in terms of how to reduce your alcohol use. So it's not just what the risk is, but how can you meet your target if you want to set a new target. So I just want to go over the guidelines here. The Canadian guidelines, you'll see we use risk zones. Overall, I just want to say that if you standardize across standard drink size and the lifetime risk, so what the definition of risk we're using, it's the same for Canada, Australia, and the United Kingdom. So it's not so different. So Canada doesn't do anything different other than risk zones, which seem to be quite effective in terms of getting people to rethink their drinking. So how do those guidelines actually affect drinking? Because part of those guidelines is disseminating the knowledge that alcohol use can cause cancer. Well, we actually did a survey of Canadian adults. 40% were aware of the link between alcohol and cancer. And when they learned about that link, what it was associated with, when you look at the states of change model, was that adults were preparing to reduce their alcohol consumption. So they said that they had the intention to decrease their alcohol consumption. However, when we looked at it in a bit more fine detail, it wasn't associated with action and it wasn't associated with maintenance. And what that means is the link between alcohol and cancer can get you over the hill in terms of get you to prepare to reduce your alcohol use, but it might not be enough to cause action. And it definitely isn't enough to cause maintenance either. So that link between alcohol use and cancer is great, but it's not enough to cause change alone. There needs to be other information provided to these individuals to promote action and maintenance. Another thing I just want to mention is that the knowledge of cancer risk was highest among those 55 years of age and older. So the cancer risk and the knowledge of it was disseminated predominantly to people older in age. And that what that means is the dissemination of this knowledge and the uptake of it is actually biased, and that young people aren't hearing the message that alcohol causes cancer. And this may be a bias in the media that they're consuming, that people who are older in age may be consuming media that highlight the link between alcohol and cancer, where young people aren't consuming media or aren't in social groups where that information is communicated. And that is a problem and a potential area for targeting change. With that, I'll end my presentation.
Thanks so much, Kevin. Thanks to both of you. Super interesting presentations. I think fantastic, and covers the whole, the whole area fully. So the evidence and the policy implications as well. And I think great to see that, I mean, a lot of the evidence has been around for a long time, but there's also emerging evidence that that confirms things that we knew as well about the policy, which ones are best buys. And I can see that there has been a lot of interest in the chat for the studies and the fact sheets that you both have mentioned, and we've been trying to put them into the chat, but we'll also try to share the recording and the presentation with everyone who attended the webinar. There were a few questions that have already been answered in the Q&A, but I think we do have 12 minutes, and I think no new questions. So I think some of them could be interesting to cover here as well online. There was a question about liver cancer, because I think that's also one of the ones you hear a lot about. But in your presentation, Harriet, it was not the most common cancer, right? So could you say a few words about that, about liver cancer? Mm-hmm.
Yeah, sure. Yeah, it's true that if you think about alcohol and cancer, liver cancer might be the first thing that comes to mind among a lot of people. And yeah, so Eric's question was, yeah, just asking why does liver cancer come out lower than, for example, colon cancer when we look at the attributable burden. And so this is because liver cancer is much less common than colorectal cancer or breast cancer in the population, so has yeah, lower rates than those other cancers, at least in Europe. And so when we look at the proportion of liver cancers that are due to drinking alcohol, it is a very large proportion of liver cancers, like within the cancer type. But then when you look at the number of those cases and compare them to other very common cancers as well, like breast cancer and colorectal cancer, then it does, yeah, come after those very common cancers in Europe. But then I also added a link to the global study where we found that liver cancer was the second most common cancer due to drinking alcohol at the global level. And that was second to esophageal cancer, and then breast cancer was the third cancer due to alcohol. So yeah, if you would like more information, definitely check out the global study as well.
Thanks a lot, Harriet. And I can see there's a new question in the chat, which I think is for Kevin's presentation, whether you can tell us a little bit more about the diminishing evidence around brief interventions and their efficiency, I guess. Mm-hmm.
Yeah, so this was a systematic review by Kainer et al., which looked at just brief interventions and the effectiveness of them. And what they looked at was the year of the study and how big the effect size was. And it's seen in various different technologies when you have the earlier studies and then you have the later studies. But typically what happens is earlier studies will overestimate the effect, and then it'll trend towards the true effect. And that's what Kainer was trying to show there, was that the earlier studies may have been done very rigorously, and may have had certain methodological differences that led to an overestimation of the treatment effect, where you would not expect that effect within public health practice. So if you're actually implementing it within doctors' offices, what you would expect in a clinical trial isn't really what you would get in real life. And so as you get towards more the real life scenarios, the effect goes down. And that's probably what the true effect is when you're implementing these interventions, not what the original clinical trials were doing, which was quite rigorous and not realistic to implement across the population.
Thanks, Kevin. Thank you. And one more question came in the Q&A that I think Jürgen would like to answer live. It's about something that you both, well, I don't know if it was both of you, used in your presentations as well. So the concept of harmful use of alcohol that we often meet in WHO publications as well. So what does this mean? How is this defined, considering that there are no safe levels of alcohol consumption when it comes to cancer risk? Go ahead, Jürgen.
Well, the term harmful use of alcohol, first of all, is defined in various ways in different WHO publications. First, it is part of the ICD, where it is very clearly defined as alcohol having caused harm. So this is harmful drinking, not necessarily alcohol use disorders. However, it has been used also in other contexts, especially as a compromise in the World Health Assembly when WHO wanted to pass resolutions on the effects of alcohol, and a number of countries were against it, and they say we should only speak about the harmful use of alcohol, as if there is a non-harmful use of alcohol. This has led to a number of problems in definitions and unclarities about the term of harmful use of alcohol. It still persists because it was a political compromise between countries. However, we are moving slowly away from the term harmful use of alcohol. And in the European, WHO European region, they speak about use of alcohol, not the least because there is no safe levels of alcohol consumption with respect to cancer. So overall, summary, it was a compromise term for political reasons, which is in the documents of the UN actually operationalized as per capita consumption, i.e. as all use of alcohol, but the term itself was this compromise for political reasons, and quite often such political compromises lead to a little bit of confusion.
Thanks, Jürgen. That's very useful. Any more additions to this? No, then I think we can take a final question as well. There was a question about, I think, individual level things that people could do to reduce alcohol consumption. The question was, except from establishing an alcohol-free day, what other alternatives could people implement to combat alcohol consumption? Because you have been talking about population level measures, but would you like to say a few words on individual?
Sure. So firstly, for alcohol-free days, the evidence on that is mixed, especially with liver cancer and liver cirrhosis. the thought is that alcohol-free days actually may that actually may cause a liver holiday, which may improve your risk of cancer. So, on the flip side, it may encourage more heavy episodic drinking. So people are a little bit wary of alcohol-free days. And so a lot of countries are no longer recommending alcohol-free days. But in terms of interventions, what is usually recommended is that people track their alcohol use through a drinking diary. So just by measuring it, you're more aware of it. So a lot of studies have looked at people just being able to remember their alcohol use retrospectively, and they underestimate it by a lot. So people largely are unaware of how much alcohol they're consuming. And so by prospectively measuring it through a diary, you can get a better sense of how much alcohol use you're actually engaging in. And that typically actually leads to reductions in alcohol consumption. So it's one of those funny things where in epidemiology, we always say, if you want to change something, you first must measure it. And that may apply on the individual level as well.
Great, thanks so much. Jürgen, did you want to add something to this? No? Sorry, I thought you looked like...
Unnecessary.
Okay, great. But then I think we have no more open questions, unless someone has something to add as well on any of the points. We can see many emails that we'll be sending through presentations too. Thank you so much, Harriet, Kevin, Jürgen, Maria and Eric for joining me today, for the wonderful presentations. This has really been great. You can see in the comments as well, everyone saying big thank yous. So thanks so much. And for everyone, join the next webinar as well on the 25th of July. Thank you and have a lovely day. Bye.